Well, thank you for having me, and thank you, Dr. Wexler, for that presentation. For what it's worth, I've noticed post-concussive-like symptoms in my patients with EDS for a long time, and I too have searched the literature and haven't been able to find anything, but I've noticed the pattern. So thank you for shedding some light on that. Disclosures, I'm the owner of Movewell Collective Physical Therapy Clinic, and it's also a wellness studio in Charleston. I started practicing in Chicago 15 years ago as a PT, and somewhere along the way discovered that I had EDS. I just yesterday came from Duke, where I was treated at the CSF Leak Clinic. So I am very grateful to be here standing with you today. I am a visiting research scholar at MUSC. I was working on the vagal nerve stimulation study that Dr. Kautz will be presenting on later this afternoon. And I have 30 years of teaching movement experience. So I was a professional dancer and initially was teaching movement to little kids, so dance, gymnastics, and then moved on to adults. Got myself certified in Pilates and yoga and all kinds of different movement, personal training. When I injured out of dance, I really wanted to find ways to heal the body and help others work with their body in ways that could keep it healthier. And ultimately, I felt like with fitness, I didn't have the right tools for that, so I went back to get my doctorate. I specialized initially in orthopedic and abdominopelvic health because, honestly, that's what I needed the most help with at the time. And it wasn't until I developed symptoms in other systems when I got diagnosed with all of the things listed here. And I, of course, see patients who have those things and more because I see a good volume of EDS patients, hundreds over the years. And what have I learned? Well, I did learn eventually to stop doing this. The hard way, as you can imagine. I was in a dance company where the choreographer really liked that move. I was the only one who could do it. And so I rolled around on the floor like that, and I hung from the ceiling, and I spun like that until one day it did start to hurt. And you know, whether you're hypermobile or not, if you take your joint to the end of its range and you don't use your muscles to support it, and you just lean into your ligaments and your joint, eventually that joint will get irritated. So I learned that. My getting very involved in Pilates and opening Pilates fitness studio was really in large part because I needed to learn how to use my core to support my hypermobile lumbar spine. Pretty obvious, right? Hindsight is 20/20. But along the way, I've also learned that hypermobility is more than just joint wear and tear. Right? It's not just mechanics. It's definitely not just joints moving too much. We've already seen there's nerves that are moving too much. There's a brainstem that might be moving too much. My biggest issue right now is vessels that are moving too much, that are getting pinched off and causing CSF to not flow, and then pressure on my brain causing CSF leaks to occur repeatedly. I had no idea all of that was related to me being very flexible, which was rewarded in gymnastics and dance. Who knew? So I didn't just need to learn how to control my muscles, which I could do very well as a professional dancer. I had a high degree of motor control. I could do that, no problem. Biomedical is important. Biomechanics are important. But we also have psycho-emotional. Thoughts and feelings have a direct impact on our body's physiology. That's not to say anything of what we're dealing with is like in our head, just that what happens in our head also happens in our body. So kinesiophobia is highly correlated to pain intensity, proprioception, and functional outcomes, right? It is normal to have fear of something that hurts. When, for example, I had a patient who would roll over in bed and her shoulder would dislocate multiple times, repeatedly. So you have to work with that. Otherwise, you set up a repeating loop. Something as simple as a gratitude practice reduces inflammation. We know we're at risk for inflammatory issues, so we can include a gratitude practice in our self-care routine for longevity, right? PT can be more than just physical mechanics. Social. I'm pushing myself a little bit to be here today because this is a meaningful event to me and because I want to be able to be with my tribe, right? Social isolation increases systemic inflammation, and there's a lot of awareness around this since COVID. So, yeah, I'm pushing myself, but I'm also getting some significant gains from being here with you all and those of you watching online. So thank you for the opportunity to be here with you. That's my gratitude practice for today. What can PTs use to guide your care? It used to be a little bit like Dr. Wexler's slide where you put it into PubMed and nothing really came up. And then after a while it was, well, we know that exercise is beneficial, PT is beneficial, but we don't know what kind. So that wasn't all that helpful. You see the pyramid here. I don't recommend animal studies for PTs. We work with humans. But case reports, narrative reviews are where experts look at the literature and see what's available and summarize it. We get a lot of expert opinions, but I don't know how many of you are patients, if you feel comfortable. Okay, yeah. Proud to be a zebra. Okay. How many times have you been to an expert and then gone to another expert and they have a different opinion? Oh, yeah. Yeah. Yes. Because we haven't agreed on a consensus yet. We don't have enough research to say, yes, we have clinical practice guidelines to say this is universally what's best. So that can be confusing. We have some observational studies. It's more clear when we get a randomized controlled trial. Even better if we can get a systematic review that looks at all those randomized controlled trials, or meta-analysis. We're definitely not at the point where we have a clinical practice guideline yet with interventions, conservative interventions for EDS. But what trumps it all is listening to you, listening to your patient, and individualizing the care to their needs. Your feedback, your preferences, what's worked in the past, what hasn't worked in the past, and then whatever it is that we try, because it is going to be trial and error, what's working? What isn't? What is your response? And then adjusting however we need to so that it will work for you. Therapeutic alliance. Now, this is where we start, when we don't have enough evidence on the patient population, we do make a leap and say, well, what similar populations do we have strong evidence for that we could extrapolate and make use of? We've got solid evidence on chronic low back pain, so much evidence on that. Many, many types of physical therapy have shown to be effective for chronic low back pain. And so this study looked at which is best. And what they came up with was rather shocking. They said, well, none of these strategies were better than the other. the thing that made the biggest difference was the patient's rating of therapeutic alliance with their physical therapist. It didn't matter so much what they did, but how well they connected and bonded with their therapist. How much they felt heard and seen and cared for. That matters. Consider that you will spend a lot of time with your physical therapist, more than other clinicians. So even if you can't find somebody who is the expert in EDS, if they're willing to learn, they're willing to listen to you, they're willing to do this process of an individualized, adapted plan of care for you, that's gold. Right? And then compassion. Yes, they should be compassionate with you, but compassion is a two-way street and it has benefits for both parties. So whether you're giving or receiving compassion, it is a natural painkiller. It's an endogenous analgesic. It promotes well-being and healing and pro-social behavior, which can help with constructive communication. And sometimes our interactions with healthcare providers can be difficult, so maybe that would be helpful. But you might just try it now. And you can be very kind and give yourself some self-compassion. You can think of somebody else who is struggling. You can think of all the other people with hypermobility, symptomatic hypermobility and EDS that are having a hard time. But whether you're giving it or receiving it, you get some benefit. If it's an advanced practice, if you can offer it to your healthcare providers who are struggling to care for you. I've been on both sides, so I know how that works. So, brief review of the literature. I could talk about this for days, but you guys have to move on, and there's lots of other good speakers. So, systematic review. This is where they look at all the literature that's out there. These are all randomized controlled trials, so this is exciting because we have good, solid, randomized controlled trials now. We've got solid evidence showing that exercises focusing on proprioception, feeling where your body is in space. We've long known that people with hypermobility have deficits in proprioception. Training it, retraining it, making it stronger is helpful. It reduces pain, improves function. And then they looked at general exercises versus local exercises as well, targeting to where you have the problem. And they found both are useful. And this is incredibly important for when you have pain in an area and you're trying to work on it and it's just getting aggravated. Yeah, you can work everywhere else and still get the benefits. You don't have to keep poking at the bear, right? Strengthening into a knee neutral position versus a knee hyperextension position, which is just really a normal range of motion, both are effective. And participants perceived that going into their natural hypermobile range with proper muscle activation had more psycho-emotional benefits because they didn't fear their own body's natural movement. If you can imagine, for those of you who aren't hypermobile, if somebody said to you, just live the rest of your life moving only about 70% of your range of motion. It's kind of hard to do. It's rather anxiety-provoking. So for many people, if you can work up to feeling strong and capable throughout your range, it takes a load off. I thought these were a little bit hopeful. A study that looked at people with hypermobility found that they can strengthen at the same rate as other people in pain. Their increase in strength related to their decrease in pain. we just have to be really clever about how we get the strength, and we might have to try a gazillion different things, so your PT better be really creative and keep coming up with different ways to do things so that you can get the benefits of exercise without the cost. 45-minute group exercise focusing on spine and core stabilization, general pain relief, increased strength, improved postural stability, and another one of the proprioception interventions also is delivered via group, which I think is a viable method for long-term and longevity, because insurance isn't going to cover individual PT forever. That's not how it was designed. It's designed for acute cases of pain. So, randomized controlled trial looking at inspiratory muscle training, improved inspiratory muscle strength, which was interesting because they found that people with EDS had a deficit in that. The result was their lung function improved, and they had improved exercise capacity. So if you're not tolerating exercise, there's another option. You can do inspiratory muscle training. Most people can tolerate breathing, right? If you're not tolerating a lot of movement, that might be a good place to start. And you see that in the POTS literature as well, that inspiratory muscle training actually helps drive down the tachycardia. So this is another systematic review now that looked at shoulder symptoms in EDS. And they found generally that both low-load stabilization type exercises and high-load heavy lifting type exercises were effective in reducing shoulder pain, improving markers of stability, and improving function. So you have choices. I'm not saying you have to do one versus the other, but if I have a patient who doesn't enjoy doing the tiny little movements with the motor control and they're getting really frustrated, hey, we could try something else. How do you feel about that? Right? You have choices. You have agency in your care. Specialty physical therapy. As I mentioned before, I had pelvic and abdominal issues. I became a pelvic PT. I found a narrative review on hypermobile Ehlers-Danlos Syndrome and disorders of the GI tract. We have functional gut issues. We have slow transit. There are abdominal massage techniques and visceral manipulation techniques that you can use to help move things along. You just have to find yourself an abdominopelvic specialist who also is aware of EDS. It can be done. You guys are good at finding specialists. You're good at self-advocating. And feel free to have people contact me. And as long as your PT is willing to learn, I do professional mentoring. I teach courses on this stuff, right? Pelvic floor coordination for relaxation is something else that we focus on in pelvic PT. And then pelvic PT for jaw pain is also considered more of a specialty thing. Working the jaw both externally and intraorally for orthopedic manual therapy to get the jaw moving better and aligning better, and then doing some motor control exercises is effective. And the study found that it was effective both in a normomobile population and hypermobile population. So then I could spend an hour talking about this, but I won't. I'm just going to say there are just a lot of evidence to support that graded exercise does work for retraining the autonomic nervous system. People do feel better, function better, faint less when they do a progressive cardiovascular exercise program. And this recent scoping review summarizes that. And then this more recent systematic review, 2025, said yes, but there are high dropout rates, and these people have comorbid conditions that are very difficult to manage. And I went, yeah, exactly. So what do we do about that? And I'm not sure why the image didn't show up here, but the Utah ADAPT protocol is currently in review for being tested clinically. But I've been using it for a couple of years now, and it is so much better than its predecessors. I wish it had been around when I was diagnosed with POTS. But it involves a comprehensive evaluation, highly individualized program entry, and exercise prescription. And then all along the way, the patient drives their progression. So you get to decide when you advance within the program. I don't make those decisions. You decide when you're ready to progress by way of moving up to the next stage or changing up the mode. You're in control. And it really helps you adapt to your needs, and because I'm much less likely to provoke symptoms. And I've noticed far fewer dropouts. It helps you build confidence that you can learn to work with your body, and not that it's workable, and that you can adapt. Because that's what the hypermobile body does. It adapts in various ways. So PT for recovery and longevity. I'm a firm believer that PT should be one-on-one with your PT and not with a rehab aide who it doesn't have a license as PT. It should be individualized for you as a whole person, not just a piece or a part. And then calm stuff down before you build stuff up. Build a toolbox of things that calm the nervous system, calm the pain, soothe, so that when you do start to build stuff up and things get aggravated, you have things that you know can bring it down a notch. If you jump ahead too soon, too much with trying to build things up, you all know what can happen. So reclaim the joy of movement, right? And this is unfortunately where insurance sometimes limitations they often just want us to get you good enough. And I just think that we need to help you find movement that is meaningful and purposeful and helps you connect to your tribe and helps you find a sustainable way of being in the world. And sometimes that may mean locating group exercises or group exercise classes or online services or something that helps you sustain long term. All right, so I do offer some of these services in Charleston and online, including instruction of hypermobility topics for healthcare professionals. So I'm passionate about that. And this is an example of, okay, that picture got stretched out somehow, but enhancing proprioception, this is one way you can do it. I have aerial hammocks, and you can lie in the fabric and feel your whole body in a compressive fabric and move around in a totally different way and feel proprioception, feel your body, and feel kind of safely held. And again, it's something that we try. If my patient says, I don't like how that feels, then go back to the drawing board. We'll try something else. There are also weighted vests you can use and all sorts of things that you can use to enhance proprioception. I put laser beams on people's heads and we just get creative until we find something that works. So I'd be interested to hearing any questions or hearing from any of you, but I know we're short on time, so thank you so much for having me. And Did anybody have a question? Oh, we have one.
If you've worked with any patients with like pectus excavatum kind of comorbidities, do you know if things like the cardiopulmonary rehab or like the inspirational breath training, stuff like that, do you know if that can be effective? Because I was told by my cardiologist that they spoke to like a physical therapist who does that, and they said that it wouldn't be, and it would actually make my POTS worse, and I was like, that doesn't sound right.
I mean, the things that I do like that are generally conservative enough that it is worth a try. And then if you try it and you tell me this doesn't feel right, or we see that it isn't working, then we stop. Unless your doctor said, no, that could be harmful, it's certainly worth a try. It's such a low-risk intervention, right? And it's also something that you can grade, just like the graded aerobic exercise. The ADAPT program actually has people start with lying down with their legs on the wall. You start at your level, whatever you need, but for people who are pretty severely deconditioned or really in need of something gentle, have people lie down on the wall and have their legs up the wall and just kind of pedal their legs on the wall, and if that's all they can tolerate, that's where they start, right? So if we're not sure if you tolerate inspiratory muscle training, we could start with like very, very little resistance to inspiration, right? And dial it up very, very gradually to make sure that your body does tolerate it and that it will be safe for you. And then, see, will it also be effective over time once we get to a therapeutic dosage? Does that make sense? Yeah.
Thank you, Dr. Wellen.